All right, fire away, Stefan.
So, hi everybody. I'm pleased to be here today with you on April 10th, International Zero COVID Day of Action. My name is Stefan Bilodeau, and on behalf of the Zero COVID Canada and the End Coronavirus team, I welcome you and welcome everyone to this webinar, The Case for Zero COVID in Canada. It's end of day on this sunny Saturday, so you're here for a good reason. It's in fact a really good reason. We're in a critical time in Canada and even abroad, and that's time to talk about solution to this. But just before going into the topic of the day, I just want to start with some housekeeping stuff quickly. So microphone will be off, but for the presenters, you'll be able and you'll be invited to use the chat and ask questions through the chat later on in the presentations. And just want to highlight as well that you should consider that this is not medical advice that you'll hear today. That's rather information, important information on potential strategies to get us to get us all out of the wood, which we are in right now. So today you'll hear about many great speakers. So after I'll finish on my side, Dr. Gozia Gasparovich, which is a developmental biologist, will talk. Just after that, you'll hear Connor Rosinski, which is a PhD candidate and a Killian scholar. You'll then hear from Dr. Darren Markland, an intensive care doctor. You'll hear after that from Dr. Jeremy Rossman, a virologist from the University of Kent in the UK. And finally, the closing remark by Yanir Aryam, which is the president of the New England Complex Systems Institute, but also founder of endcoronavirus.org. So let's start by talking about the topic of the day. I will share my screen. Just a second. Should be fine now. So I want to give you some context before we start with the presentation. So earlier this year, we were thinking in Canada, or many of the provinces in Canada, that we were almost in fact, the pandemic was almost behind. So that was wrong. And still, we have the population, the vulnerable populations especially, but in many provinces that are suffering because of the new variants, but also because of the lack of organization to respond to this pandemic. In the last few weeks alone, we've seen that, to contrary to what was thought before, the COVID was still leaving a trail of death in Canada, a trail of shock as well. So in that context, Zero COVID Canada, which is a group of Canadians that believes that it is possible to really eliminate COVID-19 from every province and territory as formed. And we're collaborating with other groups and coronavirus.org indeed, but also COVID is Airborne, COVID Stop, Zero COVID Alliance, the International Alliance. And today we want to talk about solutions, a solution that will help us get out of this uncontrolled pandemic. And it's touching so many countries in the world, but there are countries that have dealt with it successfully, and we want to use the best examples to do that. So we're talking about the Zero COVID or COVID Zero or the elimination strategy here. All variations on the same concept of eliminating this virus. Okay, so I was a bit too fast on the trigger. That's better now. So why Canada should adopt the Zero COVID strategy? I don't want to go too technical now. It's just to give some outline because our presenters will give you more details on some items. But there was a study that went out last week, and Yanir Bayam, one of our invited guests today, has contributed. He's quoted, in fact, in some of this portion of these studies, even some studies he's made before quoted. So this is showing, and you see on the graphs on the right, the in the red bubble you see, and the green bubble at the bottom right. So the red bubble is really the worst situation. We're comparing here economies, so the impact on GDP, and on the other side, the deaths per million population. So when you're up and on the left side of this chart, that's the really worst case. Biggest deaths per million and the biggest impact on GDP, decline of the GDP essentially. So Canada right now, you see the flag on this chart, and Canada is going up the wrong direction essentially on this chart. It's going towards the red portion of this chart. So that's why we need to take care of it quickly. So some countries have done really well. Some are identified on this chart. You see the green on the right side of the bottom. So these countries have done really, really well. That's the models we should follow. More specifically, there are a couple of reasons why we want to do something like a zero COVID strategy, to implement a zero COVID strategy. First, indeed, it saves lives. So if you eliminate the virus, community transmissions, so definitely the impact, the direct impact on death will be seen. So reductions of deaths, so saving lives. Second thing, it's elimination of community transmission will also spare people from getting long COVID consequences. Long COVID, it's still something that the majority of people don't really get, but this is important. And it's a portion, a fraction of the people that are getting this disease that will have lasting consequences. And long COVID is definitely something we want to spare the population of. The other thing which is important as well, elimination is pro-equity. So typically, it's this virus touches the most vulnerables in the population. So it touches those who have comorbidities, the older person, people which are in minorities or in poor populations. So when you eliminate the virus, definitely you reduce the impact on these vulnerable population. That's another good reason. It has been achieved in so many diverse settings so far. So countries, small and big, island and land countries, countries which have borders with huge countries which were affected, others not. But so this is possible in so many various settings that we should use it and spread it in Canada. By the way, in Canada, we already have some areas which are successful towards that kind of approach. So the bubble, the Atlantic bubble, is really a good example of how we can apply that. Same thing in the Northern Territories in Canada. You have really good, so the good application of these in some areas already. Definitely the bigger provinces have not been successful applying things like that, but they need to do so quickly. And it's complementary to vaccination. Should not wait for vaccination to be doing all the job. Typically, it takes time. In Canada, it's even worse than in other countries because we don't manufacture our own vaccines. So we need, in fact, we rely on others. That will take time. We cannot support the deaths and the long COVID consequence that much time. Last thing I want to talk, and I will let our great guests talk further, is how we can deploy that. There are 6 things that needs to be done to have a proper elimination strategy applied, the zero COVID strategy. First, explicit goals of COVID eliminations need to be said loud and clear. So you see the small boy on the right of my slide. So it needs to be loud and clear, and from the authorities, from the governments, and then the population can understand and define what it's doing to eliminate this virus. Second thing, something that we all know a bit more, travel restrictions, not only international one, but interprovincial one. They are really important. Lockdown are involved as well, but we talk about financially supported lockdown done properly. Fourth item is related to school. So in-person learning should be applied as much as possible, but for some exceptional conditions, whether it's because of the conditions of child or because we're talking about the children of essential workers, that's exceptions. The main application should be on online learning. I think I said the reverse. So online learning should be done much more than in-person learning. I will repeat it correctly. Test, trace, isolate, that needs to be done right from as soon as we control the virus. This is an important thing to make sure it's kept under control. It needs to be funded. It needs to be generalized as much as possible. TTI, that's called in other countries. Airborne precaution needs to be put in place. The aerosols transmission needs to be taken care of in all high-risk settings and beyond, including the explaining to the population for their own houses how to deal with that correctly. So that's it for me today. I will let now Dr. Gojia Gasperovich talk to you about this, our works. Go ahead, Gojia. I'm just stopping. Sure.
I think I was muted. No? Good evening, good afternoon. I would like to talk about the dynamics of COVID spread. And so COVID is a phenomena in terms of how it's spreading, similar to melanoma cancer, mice infestation, or wildfire, in the way that you cannot just have a little bit of it. If you have a little bit of it, you are in danger. So, for example, if you have 5 melanoma moles and you remove just 4 of them and leave 1, you risk that it will spread and you will have cancer. So to be safe, you have to remove all of them. So the same is with COVID. So basically, it can either go down when there are restrictions in place, or when restrictions are lifted and there are cases, then it will start replicate and it will start grow up. It can be sometimes slow, like doubling every 60 days, and sometimes it can surge into a big wave. So this graph shows two Canadas, two different paths that Canadian provinces took. So the gray one is 6 provinces that have COVID, and the colorful one are the Atlantic provinces that basically have zero COVID. That follow the zero COVID path. Also, the north followed this path, but I don't have graph for them. So the gray thing, the gray provinces, they followed the mitigation strategy that failed. So the aim seemed to be to protect the hospitals and to have so-called slow burn. So the aim was to have like certain number of cases gradually coming, maybe a little bumps or gradual flow. But it didn't work because COVID is not working like that. So basically, as soon as restrictions were lifted, it started to grow, and then we had the second wave. Then we had restrictions implemented. The cases were going down, but again, we opened before going to zero, and now we are in the third wave. Totally different scenario is in Atlantic Canada that followed implicitly the zero COVID path. So they had, in the spring last year, they shut down, they closed the borders, each province by itself closed the borders, and then each province removed cases, like had the lockdown, strong lockdown, till they had no community transmission. Once they had no community transmission, they started relaxing the measures. And then the provinces, the 4 Atlantic provinces, reopened to each other. So they didn't have travel restrictions between each other. Only there were travel restrictions from anybody from outside that needed to quarantine for 2 weeks. And then they protected their status of zero COVID for the basically whole summer. They had no community transmission. There are little peaks here, but they are the imported cases that were in quarantine. Then in the fall, there were some little flare-ups, but they were all quenched. They were all stamped out. And you can compare them, how different they are to our gray second wave in 6 provinces that have COVID. And what is important in this graph, it's adjusted for population. So it's cases per 100,000 people. And some of these last peaks in Atlantic Canada are interesting because they involved B117 variant. So this variant that is more transmissible. So although that was this dangerous variant, they still managed to contain it, which didn't happen in countries and regions that have the mitigation strategy on. So it's possible to contain B117 if you have Xerocovid in place. So here's another graph showing the difference between COVID permissive provinces and the provinces that went for Xerocovid. It's again current cases per 100,000 people, and the difference is really huge. And the number of cases, of course, translates to deaths, to long COVID, to absence in school, to school closures, and so on. So where we are now, we have, so this graph is Alberta. It shows daily new cases, the black dots, over time. The red dots are B117, so UK variant new cases, and the blue ones are old variant new cases per day. So we see that we opened somewhere here in February. We started to loosen the restrictions. At the same time, we already knew that we have B117, and we knew that it's growing exponentially and how fast it can be. And it was doubling then every 10 days, so much faster than our second wave. It now took over, but it's not dangerous when it takes over. It's dangerous basically when it's present and it's growing exponentially. So we see the old variant doubling. It's also growing and it's doubling every 50 days. The new variant is doubling every week, every 8 days. And if nothing will change in the conditions, we can expect 2,000 daily new cases by mid-April in Alberta and 4,000 at the end of April. And what is important here is this difference between the rate of growth of the old variant and of the new variant. New variant is 36% more transmissible in Alberta. So we have the same conditions, and the same restrictions acted different, have different result on both variants, and much smaller result on the new variant. So now the question is how strong restrictions we need to bend downwards this variant curve. And so those two graphs are like mathematical, it's mathematical modeling of starting from 1,000 daily new cases, how fast the decline will be under different conditions. And it's based on our experience, how fast it was for the old variant. So both Alberta winter restrictions, spring restrictions from last year, and the restrictions from New Zealand, Australia, and Europe from the first wave, they all bend the curve with the old variant. To different degree, like it was the slowest decrease was during Alberta winter restrictions. The fastest decrease was in the regions that implemented strong lockdowns in the first wave or second wave. So with the strongest restrictions, basically one can get from 1,000 daily new cases to 0 in just 45 days. But now with B117, that is 36% more transmissible, the restrictions that we had in Alberta in winter won't bend the curve. They will slow it down a little bit, so it won't be doubling every 8 days, but it will be doubling every 2.5 weeks. So the expected speed of it is the same as the speed of growth during the second wave surge. If we would implement restrictions like from spring last year, then we can bend the curve, but just barely with B117. So it would still take us 90 days to get from 1,000 to 100 cases. To have a reasonable decline in cases, we need something like Austria had in the first wave, or New Zealand or Australia. Then even without the vaccines, in 90 days, we can get to 0 daily new cases from 1,000 cases. Here's the modeling I did last week. assuming that if we would make a lockdown at the beginning of April, that's how fast we could get, including the vaccination effect, how fast we could get to 0 community cases in Alberta. That's for Alberta. That's not for the whole Canada. So we would need like maybe 10 days to get to the peak. That's average time observed in the first wave in Europe, from lockdown to the peak. Now the old variant is almost irrelevant. If we would have only old variant in such conditions, in 7 weeks we could get to 0. But now the new variant is driving the spread. And it's more stubborn. So we would need at least 10 weeks to get to 0. And of course, now it's not April 1, but April 10. Those cases already grew. So it would take a little bit more weeks probably. But it's still achievable, and vaccines help here because they reduce the R value and would help us. So basically, before summer, we can be at COVID 0 state in Alberta. And Alberta is not the best example probably in Canada because we have a lot of cases. So regions that have much less cases could get there faster. The benefits of 0 COVID are, like Stefan already talked about it. So no deaths, no more disabilities, no long COVID, no yo-yo, no start-start policy. And what is important is that it's easy to screen for new variants when we are at 0, when we don't have community transmission. We have very good screening in Alberta. So every incomer could be tested for new variants, and we could stamp them out as soon as they appear. But like now at 1,300, 1,600 daily new cases, it's very difficult to do. There are many countries that achieved 0 COVID, that where people live in little or no COVID, and so now around 2 billion people live in such regions, and we could join them. Thank you very much, and I pass it to.
Thanks very much, Kozia. Great presentation. So we will now have Connor Rosicki, which will be presenting the airborne natures and more details on that. So go ahead, Connor.
Just, you can see. Sure. All right. Okay. Back here. All right. There we go. So before we dig into airborne transmission specifically, I just want to review a few of the things that we've observed with COVID-19. So of particular importance are the super spreading events that we've seen very regularly covered in the news. These super spreading events, where basically you have one person who is infecting several others, who then they may themselves go on to transmit to even more people down the line, they aren't really linked to any particular activity or event. We've seen these outbreaks occur in a huge range of different events and activities, everything from cruise ships to church choirs, weddings, meat packing facilities, nightclubs. And if we dig into these different sorts of super spreading events, we start to notice that there are a few common features among all of them. And one of the most important common features is that these are always essentially occurring indoors. Other factors that are playing a role here with these super spreading events are things like limited ventilation, inconsistent mask use, and long durations of exposure. Something else that we've noticed with COVID-19 is that it's a very over-dispersed disease. And that means that relatively few people are responsible for the majority of transmission occurring. We're talking something like 10 to 20% of people being responsible for maybe about 80% of transmissions. And that tells us that it's very, very important to control for and to avoid these super spreading events as much as possible. If we get rid of these super spreading events, we can really cut down on the chains of transmission that make this disease so hard to manage. And another thing that we've noticed with COVID-19 is that asymptomatic and pre-symptomatic transmission is considerable. And there are estimates that up to about 50% of total transmissions might be occurring from people who, they're not demonstrating symptoms of illness. And considering that pre-symptomatic and asymptomatic people, they really aren't coughing or sneezing, we have to sort of wonder how they can be spreading this disease to others. So that brings us to bioaerosols. And what are bioaerosols? Well, they're basically just tiny particles that are created in our airways, and they're made up of things like water, salts, proteins, and other material that can be found in the fluid that lines our airways and in saliva. And if somebody happens to be infected with COVID-19, these bioaerosols that we're producing can actually contain individual SARS-CoV-2 viruses. And it turns out that we're actually constantly creating these bioaerosols during any number of actions. So we tend to emit relatively few when we're just breathing, but we produce far, far more when we talk, when we exercise, cough, sneeze, do all those sorts of things. And some really good studies have actually demonstrated this recently, like this one here, which is essentially showing that, in this context, patients are actually producing huge amounts of aerosol during those sorts of things like, exercising, shouting, coughing. And more aerosol then has actually been noted during certain medical procedures that have been associated with an increased risk because they were thought to create aerosols. So one thing to note is that because aerosols are so tiny, we actually need fairly sophisticated equipment to be able to measure them accurately. And that's something that we haven't really had access to in the past. But we've been developing these instrumentation methods and methodologies more and more in the past few decades, and that's sort of allowing us to figure out that these bioaerosols are actually being produced all the time. One thing is that bioaerosol by itself is not necessarily dangerous. We need to figure out if we actually need to worry about them. And let's briefly talk about how these aerosols behave. Basically, physics tells us that we know that aerosols are going to spread out from the source. They're most concentrated at the spot of emission, so basically at your mouth if you're infected with COVID-19 and you're releasing these particles, and they spread out with distance. So because of how they behave, we need to keep in mind that you can inhale these things both when you're close to a person that's emitting these particles and when you're far away. You can see the motion of these sorts of particles if you look at a time series of images. It's actually occurring for a sneeze. You start off near the mouth, and it's going to spread out over time and sort of go out throughout the entire room. And just like cigarette smoke, bioaerosol can build up in occupied spaces over time. And the concentration of these bioaerosols, if you have a poorly ventilated space, is going to increase over time. And it'll increase, the longer that people spend in that room. Something else that the science tells us is that we always have some convective and buoyant motion that's occurring with, breathing, talking, and coughing. And this means that bioaerosol is basically always going to tend to spread out in a room with or without the presence of ambient air currents. So as a result, the idea of there being like a safe distance between people when you're indoors, it really loses meaning. The whole 2-meter rule doesn't really apply when you're talking about inhalation exposure indoors. So probably the most important question that we need to answer is whether bioaerosol that contains SARS-CoV-2 virus, whether that bioaerosol is actually infectious. And we've had several studies that have found viral RNA in air samples, but this is not actually totally indicative of infectivity because viral RNA by itself can actually come from dead or inactivated virus. But it turns out that culturing live virus from any disease is notoriously difficult from air samples. It's so difficult that it hasn't actually been done with measles and with the measles virus, and measles is pretty much the gold standard of what's considered an airborne disease. But the rather amazing thing that has been done with SARS-CoV-2 now is that there's been at least one study that has actually successfully cultured live virus from an air sample. And this was done by a group that was looking at air samples inside of a room with COVID-19 patients. This is a very, very strong finding, and it actually lends a lot of support to the idea that bioaerosols can act as a vector of transmission. So and if we couple that fact that we've had live virus, we're seeing these arguments from the basic sciences. You've got super spreading events, pre-symptomatic transmission, and what we've observed is the vastly increased risk of transmission occurring indoors. All of this is sort of pointing towards the answer that yes, bioaerosols are playing a very important role in the transmission of COVID-19, of SARS-CoV-2 rather. So knowing that bioaerosols are important, what are some of the things we can start to do to address them? Well, for one, masks are actually extremely useful here, and they do two things. One thing is that they help to reduce the amount and the spread of aerosols from the source. So they reduce that from an infected person, but they also provide some protection to the other people in the area who might be exposed to that infected person. And there are three very important factors that tell us how to optimize protection we get from masks. These are filtration, breathability, and fit. And to maximize the amount of protection we get from masks, we need to use materials that have a high filtration efficiency of aerosol particles, but that also give us a fit that makes sure that we're breathing through the mask and not around the mask. And there's been a lot of great infographics that have come out on this. One example is sort of down here on the right that is summarizing a lot of this information. You know, in the past few months, we've had a lot of Canadian suppliers who have stepped up to begin manufacturing and distributing better masks and respirators. And if you're actually interested in trying to find one for yourself, there's a good list that's been compiled by one of these advocacy groups, which is Masks for Canada. Now, I'll just note that respirators are actually fantastic tools to reduce your exposure to bioaerosols, and we really aren't using them nearly as widely as we should be. Given that we don't really have the same supply issues we had early in the pandemic, I think we should be doing everything we can to be getting respirators to essential workers, you know, the people who are facing the highest risk of exposure in their day-to-day activities. And what about mitigating inhalation exposure in general? This is a really good infographic that provides a quick summary of what are considered to be safe activities or good measures to implement, you know, in green, and what are some of the things that we need to avoid as much as possible in red. And at this point, we actually need to be avoiding indoor gatherings as much as possible. But, you know, if we do have to go indoors, and sometimes we do, you know, there are a number of things you can do to help reduce your risk of exposure. These are things like well-fitting masks, you know, making sure you're maintaining physical distance, avoiding crowds as much as possible, reducing the time you spend there. These are all really good things you can do to help reduce your risk of exposure due to inhalation. And another really useful tool that you may or may not be aware of is actually, you know, implementing carbon dioxide measuring, because carbon dioxide the amount of carbon dioxide in a room can give you a good idea of roughly how good the ventilation is in that space. The lower your level of carbon dioxide, the better. And once you get below about something like 450 parts per million, you're basically at outdoor levels, which is indicating that you have fantastic ventilation and you're really avoiding any potential buildup of bioaerosol over time if you're sharing that space with somebody who may be infected. So it is important to be able to have outlets and activities to do. You know, if you can get outdoors, if you can maintain physical distance, you know, and avoid crowds, you can generally consider that a pretty safe activity, and it's a good way to avoid being stuck indoors at all times. So generally, this is good to do, you know, avoid the indoor stuff as much as possible. And, you know, the last slide here, I'll just reiterate some of the various ways that we can mitigate transmission indoors. Lots of different things we can do. You know, regular and consistent masking, upgrading to better masks and respirators, you know, improving ventilation. Ideally, you're aiming for very high air exchange rates. You know, incorporating HEPA type air purifiers, opening doors and windows, reducing exposure times, consistent physical distancing, you know, obviously good hand hygiene plays a role too. And, you know, considering using things like monitoring CO2 to inform, you know, how good the ventilation is in these different areas that we're gathering. What do we want to avoid? Well, we need to avoid any non-essential indoor gathering. You know, indoor dining is a good example of something that we should not be doing at the moment. And we should be moving events and gatherings outdoors as much as possible. But if there are scenarios where indoor gatherings are necessary, you know, we need to consider implementing many or as many of these layers as possible, really, to mitigate transmission risks as much as possible. And a good way to think about this is sort of the Swiss cheese model of risk mitigation, where, you know, the more mitigating measures you put in place, you know, it really reduces the chances that if one layer fails, it doesn't necessarily result in a transmission. So if you add in these multiple layers of protection, you can make it so that the failure of one layer, you know, does not result in an outbreak occurring. And I think given what we're seeing with the increased transmissibility of the variants of concern that you know, Gojia was talking about, we seriously need to consider pushing to incorporate as many of these layers as possible to prevent transmission moving forward. And, you know, tying this in with Xerocovid is that Xerocovid is a much safer and more sustainable strategy to control transmission than it is to implement all of these factors, especially because we haven't really done this up to this point. And without all of these sorts of measures in place, we really have no hope of preventing these sort of outbreaks from occurring, you know, if we have significant community transmission already. So with that, thank you, and I will hand things off to Dr. Markland.
Thank you very much, Connor. So effectively, we'll have Dr. Darren Markland, an intensive care doctor which has a good presence on Twitter as well, easy to find on Twitter. So I'll let you talk about your.
Thank you. Thank you, Connor. This is a STEAM company to be in. I'm a pretty practical guy. And most people I think out there have learned about intensive care, but probably in a way that they had never expected. As intensive care is one of the late indicators for when we bring restrictions into everybody's life. And this is probably one of the biggest reasons why I champion COVID-0. We're a late indicator. We're the last stop before you die. And that's really a situation that I don't think anybody wants to be in. The other thing for that is by the time the intensive care unit is overwhelmed, the system is overwhelmed. And so the ability to contact, trace, and control new variants is also becomes unmitigatable. These strategies that we speak of are incredibly important. Now, I'm going to show you a little bit about how the intensive care worked during our second wave. There's maybe a little trigger warning here. I'm going to show you medical images. None of them should be overtly graphic, but they are medical. And if you've had any loved ones who have suffered or been hospitalized, this may bring back some pretty rough memories for you. So this is a presentation I actually gave for Medical Grand Rounds. And it talked about the changes that happened in our intensive care unit. We had to grow. Our intensive care unit at the Royal Alexandra Hospital in Edmonton, Alberta has a 25-bed unit. Those are enough beds for between other intensive care units for a city of almost 1 million people. And it's a very stable situation. We don't get big variations. Our flu seasons get busy, but we've never had anything like we've had during COVID. COVID had us flex up to 44 beds at our peak. And that is what you're seeing right now. This is a picture of our recovery room that has been converted into a barracks-styled area for patients. And you can imagine if your mother or father was in there, this would not be a place that would allow them any privacy. This is what you have to do when you need to get as many people ventilated and looked after by batch care as possible. We went to the lengths of doubling up patients in rooms. This was a room that used to be a storage area that got converted into patient care. And as you can see, our ventilator supply became a real issue. We have finite resources. And when these are gone, we start to run out of ways of actually saving people's lives. A lot of these things were mitigated because our physicians and allied health professionals on the wards began to practice things that we normally did in the intensive care unit to prevent people from coming to us. High flow oxygen, actually doing some of the maneuvers that we do in the intensive care unit to forestall the need for mechanical ventilation. This is just an idea of how busy the place gets. We had to take in staff that have never been in the intensive care unit to help us. These allied health professionals were brilliant, but the level of care that we were able to provide was not the same level of care that we normally did. Our nurses, respiratory therapists, and physiotherapists, pharmacists, and nutritionists were incredible and worked day and night under some pretty difficult circumstances. But in the end, when we are overwhelmed, we know care diminishes and we know that outcomes get worse. At peak, we had over 200 staff. We redeployed over 100 from different places. We got a lot of them from the surgical world because when your hospital's overwhelmed, you stop doing elective and semi-urgent surgeries. And we augmented our staff. We had 5 intensive care physicians in the unit and hospital at any time, just to look after the number of cases. And we learned a lot about COVID. COVID was a disease that started off as a pneumonia, but really, it threw us off in the beginning because it acted more like a disease of blood vessels. And this is one of the things that factors into long COVID, the thing that a COVID-0 strategy will help us control. If you don't get it bad enough that you come into the intensive care unit, the chances of you getting long COVID are very small too. You can see from this picture, this is an example of what we call in the business ARDS, acute respiratory distress syndrome. These lungs are like wet sponges. And this is actually an X-ray taken from a 32-year-old man who was otherwise perfectly healthy. This is the severest form of the disease that you can get. And getting better from it takes a very long time. Our third wave is going to be much more challenging because vaccinations have been a double-edged sword. Now that our frail people who would have died, regardless of what we've done early in the game, are not catching COVID, we're left with more robust people who we have to put more effort and time into, because to lose them means so much more. That's going to stress resources even more significantly, because once you're in a game like this, and I use game in an inappropriate way, once you're in this course, you can't give up until someone decides to, which again makes family decision-making and communal decision-making incredibly challenging throughout this. We do a lot of things differently. Some of it was out of sheer necessity because of resource management, and some of it was learning on the way. As we figured out more and more about aerosolizability and generation of aerosols through different procedures, we had to change the way we ventilated people, often putting tubes directly into people with paralysis, so we didn't spread things around. We had to save our masks and PPE, which is why we went to communal nursing. That way you could put on one gown, one N95 mask, and you could get your work done with 25 patients without having to switch and potentially contaminate other workers who would come in and out of the room. We did a lot of other things, which are probably a little out of scope for the talk, but we learned a lot about the disease. And what we also learned is, because this is not just a disease of the lungs, this is a disease of everything. We saw people who had significant brain damage from this disease process. And that's not, to use a word like brain damage out in the public, is something that you don't take lightly. We know this virus can infect the brain. We've seen it grow from tissue from the brain, from fluid around it. And this is part of the reason why long COVID is probably going to really be such a significant long-term issue, because there will be brain injury. If you think fibromyalgia or chronic fatigue syndrome was severe, it's something the medical community has been trying to wrap our heads around. COVID will be like this and significantly worse. This is something we really want to avoid. When things get really bad, we also had to employ rescue therapies. This is an example of something called ECMO. And I don't know if people have seen this in the news, but this is what happens when we no longer have the ability to push air in and out of a person because their lungs are so stiff. This is heart-lung bypass, where we put large catheters into the great veins of the body and circulate blood as a last-ditch effort to keep lungs from getting even more stretched and damaged. Here in Alberta, we have a remarkable heart institute, but even with this high level of care and patient selection, 40% of people who went on this modality survived. And long-term outcomes are still being figured out to see just how injured you are if you have to go to this level of support. This is the catheter. Putting these in is no small undertaking, and you can see that there is morbidity from the interventions that we do to save lives. And you can also understand why these resources are so precious. We don't have a lot of them. And to prevent people from coming to the unit would be the goal. A big thing that has been talked about COVID-0 is equity. Equity is a big issue when you're talking about someone in intensive care, because the one thing we really worry about is having to triage patients. If you run out of resources, how do you pick and choose the people who will get them? Do you do it by age, by underlying health, by frailty? All those things have certain values and judgments about them, which bring in very moral discussions. To avoid the situation from the beginning allows equity at its purest form to exist. Like I said, these are some of our results from bypass. And this is a graph. I do this just because every scientist likes a good graph. And this shows you how severe the outcomes are in our older populations if they have to require a ventilator, a machine to push air in and out of you. Up to 84% of our 80-year-old patients did not survive this if they required it. It was a marker of severity of disease. Again, a reason why prevention is so important. With our new variants, we are concerned. Yes, we're not going to see these younger people, but the severity of the disease, the B117 variant is much more morbid, and P1 is probably significantly worse if we look at our Brazil experience. Frailty, age, all of these things show you that over time, if you're young and healthy, you're going to survive. But our concern is what you're going to be like when we're done with you. That is information that's evolving right now, and what we use to prognosticate who we should bring in. One of the things we think about are whether or not we will just watch you and see whether or not good nursing gets you through this, or use a non-invasive form of ventilation to prevent the injury from direct intubation of the lungs. And finally, once we figure out if there is a likelihood of survival, invasive ventilation and even ECMO becomes one of the things we talk about. This can affect every organ. We see liver dysfunction, we see brain dysfunction, we see kidney failure. And kidney failure late in the disease is highly mortal, not just because of the resources for dialysis, but also because when you get secondary injury, despite all the support, you know that people are literally passing away in front of you. When we talk about long COVID, we have experience in the ICU population pre-COVID with just how bad a disease is that makes you go to the ICU, how it can damage not only the way that you feel, but the way that you think. And this graph shows that people who come out of the ICU after having severe lung injuries have similar outcomes to people who have literally had traumatic brain injuries, people who've been in car accidents, ejected from cars and hit their heads. That's how severe this can be. We think COVID will pan out to be significantly worse because of the long stay that people will be on our ventilators, but also because of direct infection of the brain and spinal cord and nerves. There is physical impairment, and long COVID is a big part of this. When you're sick enough to be in a bed for weeks, you lose a lot of muscle. But also the virus does cause myositis, which is an infection of the muscle. And so people can be short of breath for a very long time. They can have symptoms up to a year afterwards, just from regular lung injury. But with COVID, we're seeing persistent effects as well. And these also roll in both into not only cognitive, but mental states, depression, anxiety. These things are scars that can last for a long time, not only just from the direct disease, but the experience of being under this situation and out of control for so long. And that weeps not only from the family, from the patient, but into the family's experiences too. This is just a quick list of all the things. We love lists in medicine, but this tells you just how long some of these symptoms can last for and how common they are. And of course, fatigue is probably the most common one. It's a tough thing to figure out because it's such a ubiquitous thing, but shortness of breath, chest discomfort, cough, even loss of smell can last for a very long period of time. And psychological and neurocognitive issues can mark us for substantially longer. Long COVID is a huge issue, which will come to plague the medical system. And again, a reason why a COVID-0 strategy, not a mitigating strategy, is the way that we really want to go with this. This is really what I had wanted to say. This is, and I will thank you for your attention and relinquish the controls to everyone else.
Thanks very much, Darren. Your presentation was definitely eye-opening, but I would say also heartbreaking at some point. You're facing situations in ICUs that are really, really difficult, I'm sure. Now we have Dr. Jeremy Rossman, which is a virologist from the University of Kent. And I'll let you go edit your presentation, Jeremy. Nice to have you here.
Thank you very much. Yeah, so we've seen a lot of really great talks here about why we should be pursuing a zero COVID strategy. And I just wanted to take a step back for a minute and say, what are the alternatives? What are we really saying zero COVID is a better approach than? And the first thing is a mitigation strategy. And mitigation is what most of us have been living under for the past year. The idea of mitigation is to reduce but not eliminate virus transmission, to protect healthcare institutions, and to shield the vulnerable population from severe and fatal COVID disease. Unfortunately, we have not done that. That has not worked. We have not, as we've just heard, we have not protected the healthcare institutions. We have seen many outbreaks in nursing homes. We have not been able to protect the economy even while doing all of this. It hasn't been successful. We have not protected health or wealth through this mitigation strategy. And I think anybody, regardless of whether or not you believe in zero COVID as a strategy or not, can look back at the past year and say, this was not a successful strategy and we would like to do something different. But the mitigation strategy is also based on a flawed principle to begin with. And that idea is that the virus only causes severe disease in a vulnerable population, and specifically in the elderly. And so that if we protected that population, that would allow the rest of the country to act more normally. And unfortunately, that's not true, because we know that children can have the very severe MIS-C disease. We know that healthy young adults can die from COVID, and we know that there's a significant portion of people that get even mild COVID cases and develop long-term debilitating symptoms that may last months to years in the form of long COVID. So this is a huge risk. It was based on a flawed principle, and it has not worked. So another strategy that people have advocated for very early on in the pandemic is this idea of herd immunity, the idea of taking fewer restrictions to protect the vulnerable population while you open up and let the virus pass through the rest of the population, to build up immunity to the virus so that then we can stop virus transmission that way. But as I'm sure you can imagine, based on what I just said, well, first of all, we haven't succeeded at protecting the vulnerable population already, so we can't do that. And if you let the virus pass through the rest of the population, you are going to be exposing everybody else to significant disease, significant loss of life, and the development of long COVID. So this really also does not work and is a huge risk to people's health. But there's been an alternate that's been proposed very recently, and this is the idea of getting to herd immunity through the vaccines. That instead of putting people at risk of long COVID, instead of letting the virus pass through the population, we still protect the vulnerable population, but then we use the vaccine to build up immunity till we get to a point where the virus stops transmitting. And to a certain extent, this is a very attractive strategy, because we do have good vaccines. The vaccines are very good at protecting people and protecting the vulnerable from severe COVID disease and from COVID fatalities. Looks like the vaccines may actually be very good at reducing or significantly reducing virus transmission. So these are great, but there are two problems with the idea of using vaccines in this way and being dependent on vaccines. And the first is viral variants. So we already have the Brazilian variant, we have the South African variant, and both of these can evade the vaccine-induced immunity. And so we can't wait, because the more cases that we have, the more viral transmission. We're getting more presence of the Brazilian variant, more presence of the South African variant, and each new case has a risk of a new variant of the virus emerging that might even be more resistant to the vaccines. So this is a real concern, but it's even more of a concern if you look at the recent governmental strategy of saying we are now going to separate vaccine doses by 4 months, because this has two big flaws in it. First of all, we do not know if you come back and give a second dose of the vaccine 4 months later, if this is going to work. The vaccines weren't designed like that. They weren't tested like that. And we don't know if it'll work. And second of all, we already know that people that have had one dose of the vaccine can still be infected by the virus. It reduces the likelihood of being infected. It does reduce the severity, but they can be infected. And so a concern here is that if people are infected with partial immunity, does that help pressure the virus to evolve resistance to the vaccine faster? We don't know, but it is a real risk. So this evolution of the virus really makes the dependency on the vaccine a risky and more short-term solution. So that's not it's not a great strategy. But maybe if we were able to spontaneously vaccinate, say, 75% of the population tomorrow, we could, miss some of these problems. But unfortunately, we are nowhere near that point, because at the current rate of vaccine rollout in Canada, there's been some estimates saying that it might take almost 10 years to vaccinate 75% of the population. And now the vaccine rollout may pick up pace over that period of time, but we are still talking about many months to years before you're able to vaccinate enough people in the population to slow virus transmission. And during that period of time, you're putting people at risk of severe disease, of fatal disease, and subjecting many people to the development of long COVID. So again, this does not seem like a great strategy. Now, the vaccines are a fabulous tool. And if we can support the vaccines with existing public health measures, with masks, with ventilation, with testing, with contact tracing, with supported lockdowns, then we can use the vaccines and work with them to get to zero faster. And so this is why in my view, and I think many of the talks that we're hearing here today, is that by working with all of our tools and not relying on just one, we can do much better. We can get to zero, and we can eliminate local transmission of the virus and really protect people's health and well-being and livelihoods, and get there much faster than we've been doing over the past year. Thank you.
Thank you, Jeremy. Great perspective of a virologist on putting all our eggs in the same basket, the vaccine basket. So thanks for this. Now we have Dr. Yania Baryam, which is the founder of End Coronavirus, which will give us the concluding remarks. So I invite you, Yania, to start.
Thank you. Thank you very much. And thank you all for the presentations. And particularly, I want to express appreciation for Darren. I've heard the other ones before, and I've appreciated them before. Darren, your presentation was new to me. And I think one of the things that's super important is that we have shielded people from knowing what happens in a hospital. We have shielded them from the awareness of what the disease looks like when someone is suffering from it. And even the statement that people are unable to breathe and they need to be helped to breathe is something that many people do not appreciate, how severe an experience of suffering that is. And I think that that shielding has led us to, in many ways, to lose the sensitivity that I think is important in caring about the consequences of this disease. Now, what I want to talk about is I want to shift gears from that statement to an awareness that at the beginning of this pandemic, there was just a mistake that was made. And this was said early in these presentations, that the mistake that was made was this idea that we couldn't eliminate the virus. As soon as the virus got somewhere, people talked about the horse leaving the barn. And that idea is just an incorrect understanding. The coronavirus is better understood as a fire. You can put it out, and if you put it out, you don't have to live with a fire. You don't have to live with a disease. And that mistake has led a major part of the world into this trap of yo-yo lockdowns, of ongoing accumulation of health consequences for individuals, and ongoing damage of economic consequences. And despite the idea that there is a trade-off between health and economics, it just doesn't work that way. That the opportunity to achieve elimination in a short period of time is the way to reduce both health consequences and economic consequences. And that realization now, 1 year later, should really be guiding the policy discussions. And it's often hard to understand how people get locked into modes of thinking, get locked into frames of assumptions that are even clearly demonstrated to be incorrect. So we see in Canada the tremendously clear difference between the provinces that have achieved elimination, that have achieved zero COVID and are living basically normal lives with mostly just the restriction on travel, long distance travel, as a constraint on otherwise normal existence. But we do not have the choice of saying we want to wave a magic wand and go back to the normal existence that we had without the travel restrictions. The choices we have are in front of us. Yo-yo lockdowns, tremendous suffering, tremendous loss of economic activity versus a rapid, strong action that can achieve elimination in 4 to 6 weeks is the standard number. If you go to smaller areas, it takes shorter. If you use larger areas in a single unit, it takes longer, but it's not that hard to do. Why isn't it being done? And the main reason I think that we need to appreciate is that it is a collective choice. Political leaders are afraid that they won't be supported. There was a very interesting statement by Jacinda Ardern, I think in the last few days, appreciating the year anniversary from her decision to make the lockdown in New Zealand. And she said, it was not clear whether people would go with us in this direction. And I think politicians are generally good at positioning themselves where the public is, but not so obviously in taking what is a traditional leadership role and saying we need to go there. I think in order for us to be able to achieve elimination, to be able to achieve the zero COVID strategy, the public has to be extremely clear about its desire to do this. And remember that most of the action is not actually a government action. It is a public action of preventing transmission, of rapidly identifying cases and isolating them. And it really is the willingness of everyone to participate in this effort that is the most important condition for being successful. This is what we have learned. Communities are the nexus of pandemic response. It's not, as we've heard from Darren, in the hospital. That's when we fail to control the disease. It's not in the government support, though government support is important. What is essential is clear information, clear understanding of what needs to be done, clear updates, daily updates of what is being accomplished. If we do it right, it goes rapidly and we need to follow it and then understand that we're arriving at a destination. Zero COVID is an exit strategy. It is a way out of this, but we have to know that we're going to walk through the exit and aim ourselves intentionally to do so. So with our efforts and the efforts of the community of zero COVID in Canada, I really hope that Canada will lead the way, as it already has. It is the provinces, the Atlantic province, the northern provinces of Canada already are exceptional in their accomplishment in the context of the world that we live in. And it seems like it should be possible for other provinces to learn from them. It is the communities responsible to make sure that the leaders understand that that's what's needed now. Thank you very much. And on this day of action, let's dedicate ourselves to make it happen.
Greatly, thank you to you, Yanir. So your point to have involvement of the community, the population is absolutely awesome. And it leads directly to the last slide I wanted to show you before we are going to the Q&A. And Josh, that you see on the screen right now, will help me do that. Don't hesitate to take the puck, Josh, if you need at some point. So I will just share the last screen, which is directly linked with the point Yanir was talking about. So it's a call to action to all of you and your communities to help in pushing and make sure that the zero COVID or the elimination strategy is used as that has been really well done in some provinces already. Many are failing, but others are doing well. We would like all Canada to be at the same place. So you have the capacity to sign, for those who haven't done it yet, the open letter that Xerocovid is sending to the authorities, the officials. It is on an article in Ricochet today, by the way, just for you to know. You have the petition from COVID is Airborne to WHO, directly linked to what Connor talked about earlier, so the importance of the aerosol transmission. Today, as Yanir mentioned as well, is the International Zero COVID Day of Action. Don't hesitate to go on Twitter, on Facebook, use the hashtag. I've just mentioned one on this slide. Contribute to spread the message, and also protect yourself, protect your relatives, protect your community, and get involved. So we're now going to the Q&A. I will just start with a general question before going to the specifics. One person has asked me directly if we will be sharing the slides, and so this presentation will be shared. Indeed, you'll find a YouTube link shortly in the coming days, and we intend to share the slides as well in the same time period. So that will be, it's a public endeavor. As Yanir mentioned, it's important the community get engaged, and we'll make sure that you have the tools and you have the ability to use what we've shared with you today. So we'll start with first question on our list.
I'll just make one note for everybody first, Stefan.
Go ahead, Josh.
Yeah, so we've actually gone very much over time, which is all right because we've had a lot of excellent speakers. But so I'll just note if any of our speakers do have to run away, since we have gone over time, that's fine. And then the remainers can answer the questions, but we've already had a considerable amount of absolutely excellent questions rolling in. So we'll try to get through as many of those as possible. And I think considering the time and how many questions there are, if anybody else has any questions, try to get them in the next, I'd say 4 minutes, and then I'm going to cut off the chat and we'll just read what we have left. So take it away, Stefan.
Thank you, Josh, for the clarification. Yes, we're a bit beyond the time we had, but we'll try to go. And everybody that needs to leave, don't hesitate, or we'll take it one at a time. So we have a question from Michelle Seymour. It's a long question. I'll try to read it quickly. It's on the chat anyway. So how can we circumvent the difficulties involved in applying the zero COVID strategy in regions that are at the same time all at once highly populated, densely populated, and highly interconnected, and also which has culturally reluctant towards the collective constraint or influenced by medical institutions that promotes mitigation strategy. So it continues a bit, but you understand. So I don't want to read the rest, but if one of you can take this question, it's really related to how we're dealing with difficult context to push this zero COVID strategy.
Take it.
Maybe Yanir, yes.
Yeah.
Anyway.
So we know how to do this. High density areas are often maybe immigrant population. It's important to engage the leadership of those communities and to have the community itself take ownership of stopping transmission. The major method for doing that is a door-to-door process, having people check in with each other on a regular basis, typically daily, about their well-being, of course, identifying cases, but also providing financial or medical support where it's needed, being aware of people who need food or other things. I can tell you that it has been successful to stop transmission, even in the largest slum in Asia, in Dharavi, which is 1 million people in a square mile of area. It is possible to do it. It does require intensive action. There are other ways that also help by mass testing, by doing targeted vaccination of areas in order to limit the transmission in those areas. So we have tools to do it. There's traditional methods. There are the new approaches that we can use, and it can be done.
Thanks very much for the info. The second question, sorry, is really towards the Albertan situation. So one of our Albertan speakers can take it. I will read it and just let me know which one of you would like to respond. So AB's premier announced this afternoon that it's from Jennifer to Nexus. AB's premier announced this afternoon that the best projections from public health show we will be able to lift the majority of public health restrictions in the month of June. Have any of you seen projection that would indicate this is a likely possibility? So Gosia, yeah, go ahead.
So I didn't see such projections, and my calculation on vaccine efficacy, probability of it, like it doesn't seem so. So it would be really great that such projections would be released. On what basis it's calculated, what they put into equation, what they assume, and like what they assume as so probably they just put into equation that how many people will be vaccinated by this time, because that's the plan. But how big efficiency against transmission of the vaccine, how big efficiency of the vaccine against transmission was assumed there? Was it 97%? Was it 100%? Was it 60%? And actually, even with 97%, probably it wouldn't get us to herd immunity. And the problem is also that unequal distribution of vaccines, children won't be vaccinated. So we will have this pocket of non-shielded people, like the big group that interact between each other, that is 100% non-vaccinated. And the other thing with this is the end goal. So open with what? Like, what's the end goal? Because vaccinations is one thing, but what we want to achieve with vaccination, do they aim for endemics, or they aim for pandemics that will be still controlled like this, or for elimination? And I think that's the question we should ask our governments. What's the end goal?
Good point. Some other comments or no? Okay, so we'll go to the next question. It's from Dex. The forecast for zero COVID assumes that restrictions are enforced. With the current surge in deviant behavior in business and people in terms of compliance with the COVID measures, what can the government do to implement a COVID zero strategy? Gosia, you want to take it as well? Okay.
So I think it's again something that government tells us in Alberta that people won't listen, but people listened. The first wave went down when restrictions were implemented. The second wave went down when the restrictions were implemented. So actually people do listen. It's the role of government here to send the proper message and say, hey, we are going for zero. Please, everybody contribute. And then people, even in Alberta, actually, there is a lot of people who do the great job in Alberta. So it will work because it worked already 2 times. That just we need to push it to zero to end the job, because 2 times we didn't end the job, but people complied. So
another good point. Some want to add to it? That's fine. Okay, just raise a hand anyway. So another question from Stephanie Atkin. So is the degree of vaccine evasion of the Brazil variant known? So I know one of the speakers spoke to this, but I missed this info and if it was given. So maybe Jeremy?
Sure. Yeah, so we do know that the Brazilian variant does evade the vaccines to some level. Just like we know that the South African variant does evade the vaccines to some level. But we don't know specifically the effect of the Brazilian variant on overall immunity to the virus, because it's not just antibody responses. You have T cell responses, you have a very robust immune response. And so we do know that the vaccines do still offer some level of protection against many of these variants, but it's reduced. And so the concern is that we're already seeing more and more mutations on top of these variants. And the concern is just things will just keep getting worse and the vaccines will get less and less effective over time. So it's still effective to some degree right now, but it is reduced.
Thanks for the clear answer. So we have a question from Dorothy Wigmore. I will read it. It seems to me that Xerocovid can be solved without accepting that the virus is airborne. It's a key justification for closing down things and stopping the spread in so-called essential workplaces, where racialized people, women, and others are forced to work. So how are you incorporating this in your Xerocovid activities?
I can probably speak a little bit to this. Yeah, this is a very good point. I think academically, the answer of whether COVID is airborne or not has been answered completely at this point. Yes, airborne spread happens. Yes, it's important. Yes, it's mitigatable. The problem is that there's a lot of inertia in the system right now that is, for whatever reason, people are not willing to actually face the evidence for what it is. So quite a few groups like COVID is Airborne is actually pushing quite hard on this, is trying to get people to actually address this evidence, because it's a great point. Unless you accept that some of these things that are being claimed to be safe really aren't safe, it's hard to justify to the public who may not be aware of these arguments that, you know, indoor dining is unsafe. Especially when you've spent the last year claiming that it is a safe activity, you know, when in fact it isn't. So this is very important. I think the more people we have asking these questions of the people in these positions, the better. Basically asking to, you know, we need to do this. We need to address this problem.
Thanks, fair. We have a question from Cheryl Strachan. So say we're in agreement, okay? So what can we do to help Alberta move towards COVID-0? So it can be by anybody, because it's a more general question. So just put it on a broader spectrum than just Alberta, but definitely it's applicable number. So do we have someone that wants to take this as how we move towards COVID-0 in a situation like Alberta? No volunteer. Okay. So anyway, the strategy we have highlighted is definitely the one that we push in the open letter. So you have 6 items that needs to be put forward. But if we go just one step behind what Yanir just said a couple minutes ago, involving population, communities, that's the key thing to be starting with as individuals.
I can.
Gojia, you want to add something?
Yeah, so at least in Alberta, in Canada, we have xerocovidcanada.org group, so you can visit our page and sign the petition. You can write your own petition. You can email your politicians. You can email your city councilors, and city councilors are really responsive to what people want and what people need. They really do care. So then they can push higher levels of the government, so it can percolate from the down to up. And in Alberta, there is another very good group of people advocating for zero COVID. It's go4zero.ca. Now we have actually the very tangible effort done, so helping essential workers, providing them with the personal protection with the N95 respirators. So whoever can donate or deliver them, or whoever needs, just contact go4zero.ca. And you can organize the group like this as well. So the more groups, the more involvement, the better, the bigger push at the decision makers.
A really good point, Gojia. Just want to mention as well, we're already at 4,500 plus signees on the letter. Many of them, and I've been aware of that, have sent directly as a signatory of it to their local MP this letter. So that's something you can do when you want to reach out locally. So if you agree with what you're seeing, you can yourself send it to your MP local. Okay.
I just want to add something on to Dorothy's point from before that actually sort of ties into what Gojia just said, is that, you know, we had a court case in Quebec a couple of weeks ago where the judge actually sided with the union that was saying that the PPE that was being supplied to workers was not sufficient against airborne protection. So I think, you know, the law is frustratingly slow in some circumstances, but that might be just about that might be one avenue to actually start to get this moving forward for the people that are setting the rules that aren't willing to acknowledge that airborne transmission is occurring. Because, you know, expert opinion really is on the side of airborne transmission being important, and airborne transmission is mitigatable. So just a thought.
Really good example, Connor, Canadian, Quebec example, really relevant to this topic. So we have a question from...
I'll throw one other question here quick, Stefan. There's a related question. It got DM'd to me and I was going to read it at the end, but it's relevant now. Are there any MPs, MPPs, or MLAs publicly on board with this strategy? That's from Elsa Zimmer.
We don't have official MPs in this endeavor. It's really a population-based, citizen-based initiative. Some MPs have seen as pushed some tweets and stuff like that in the recent weeks, in the week and a half that it has been started, but no official. So it's really starting from the citizens, from the communities. Just for you to know.
I think I saw a news item that the Green Party has come out in favor of COVID zero. Isn't that correct?
The British Columbia Green Party.
In BC, yes.
Yeah.
I see.
Okay, so we have a question from Lawrence. The zero COVID strategy worked in countries of different social and political systems like New Zealand, China, Korea, etc. Using WHO statistics, I calculated the population rate compared to the international case rates. Canada is 1.6 times, I'm looking for the questions, twice the international rate. The US is the world leader, yes, in terms of deaths and cases. So 1 year after the start of the pandemic, some countries are COVID-free due to their zero COVID strategy. Dr. Yanir is correct. He's just confirming your calculation.
I don't think that was a question, unfortunately.
So sorry for me.
I think Yanir just has fans. So
it's one of your fans, Yanir. So your numbers are right, and we know it. So yes, I'm switching to a question now. So it's for you, Yanir, by the way. So I have not seen any control theoretic analysis of the current. It's from Eric Carroll, just to mention, long delay systems that we are applying a control signal to deep in the process, late in time. So this suggests yo-yo lockdowns are intrinsic to the current approach. Any comments from Yanir on the modelers? Any known work on this?
Yeah, so we actually have done that analysis, and we have a couple of papers that have been published in conference proceedings or something. The first author is Blake Elias, and they've actually worked on developing a gamified version of this control process. The basic idea is by being in control of the process, you see this dynamic interplay, right? Because people are, who try to open up, right? They see the consequences and then they have to shut down and they open up because they're trying to open up. And so that kind of behavior is reflected in a control analytic behavior of the problem. We do have that work. If you email me, I can have Blake send you the paper if you're interested. And I'm just going to put my email in the chat.
Thanks very much.
And then you can skip, I think you can skip forward to JR, I think.
That's the one I was looking
okay.
at. Sorry, yeah.
Gotcha.
I read it twice to make sure it's a question now. So I'm learning slowly, but I'm learning. Like, anyway, cut me anytime, Josh. That's your full right to do so. So, so it's from GR. Have you been following the US reopening? Some of you on as guests are American anyway, so you might be, with a significant push for vaccine rollout alongside with many states reopening. Is the writing on the wall that it will be a Titanic-sized disaster? Question mark. That's the question. Some comments or remark on the U.S. situation as an example, if I understand, of a potential disaster. Yes, yes, no, I don't see any hands raised.
I can take it a little bit, Jeremy, and probably can help also. The bottom line is that because they're opening up before the vaccination is right. I mean, if you use the vaccine as a tool, you stay locked down and you vaccinate, and then you open up when you get the controlled situation. Because they're opening up in tandem with the vaccination, number one, it's very clear that we're getting huge outbreaks already in Michigan and Chicago and so on with the new variants. It's really hard to see what's happening there. We're ending up with the same kind of disaster that we've had before. Over 20 states are now growing in number of cases rather than declining. And as Jeremy said, if we allow the virus to transmit while we're vaccinating people, the likelihood that we will have a vaccine evading variant that will substantially undermine the entire strategy is extremely high. And in fact, this is one of the things that people are assuming is going to be the generic situation, which is endemic disease, which is not a good situation in leading into the future. So the bottom line is one would have to be extraordinarily lucky to have the vaccination process that's happening in the United States be really successful. It may be somewhat better if it controls the outbreak better. It may be worse as the variants are taking over, but the long-term outcome of such a strategy is not a very good one, as far as we can tell. Jeremy, do you want to add to that?
No, I think that summarizes it. I mean, to be solely reliant on the vaccine is a really dangerous premise. We need to support the vaccines, and we can do that, and we need to do that. You know, and yes, we are seeing in certain areas in the US, we're seeing, you know, B117, for example, like we're hearing in Michigan, really increasing in numbers and increasing in cases. And, you know, right now in a lot of areas, the vaccine rollout is really too low to make a difference. And, you know, we're a little too dependent on that sort of thinking into the future. But, you know, in areas where there is better vaccine rollout, you know, that it will help. It's a positive thing. We just can't rely on it solely.
Absolutely. It needs many tools in the toolbox. Okay, so we'll finish in a couple minutes, but I will take the next few questions. So we have Eric Carroll, which is asking, how do we get the key chief medical officers of health on the side to this approach? On the side, currently Ontario, AB, BC, I could add Quebec, are adopters of mitigation strategy. So how we get them, motivate them to go on the other side. Someone wants to open on this? So yes, Darren, go ahead.
The chief medical officer's role has always been somewhat controversial. If you look at the contract, our medical officer, and all of them under states of emergency have explicit abilities. However, the reality of the situation is that they have to be able to, just as we're mitigating the virus, they have to mitigate the political structures. And so, at least in Alberta, our governance has been such so that it's politicized the situation, made things very extreme. And as a result, knowing personally people who are in public health, our CMOH is desperately trying to prevent the worst case scenario. this really says that it's all influence, political influence, that will influence our CMOH. And so all of the things that we talk about, talking with our MLAs, with our political representatives, are critical. The CMOH will do the best medical thing. The reason we're not doing the best medical thing is because we have significant political interference against that right now.
Really good point. Interference, that's the key situation for many, many provinces right now. So we have a question from Nick Duvis. So Austria was referenced as how to get cases down to zero during the first wave. If they were so good at it the first, why not the second time when they had 7,000 cases per day and still continue to have issues?
Okay, so I didn't reference them as people who got to zero, but who had lockdown strong, so strong that the R value was 0.54 in the first wave. So such lockdown reduces cases really very fast. I think that halving time is like 5 days. I don't remember now from the top of my head, but their reduction rate was really fast, but they opened while still they had cases, so they sort of wasted this reduction and then they had growth again. So it was only to reference how fast, if you have a good measures, that then they can quite fast reduce the cases. And in case of New Zealand, it was faster than Austria. And in case of Australia, it was slower than Austria, except in Australia, they kept it till the end and reduced to zero and then stayed at zero.
Thanks. Important clarification. Thank you, Roger. From Jocelyn Lehman, any idea about the thousands of time slots for AstraZeneca vaccine rollout for the 55 to 64 years old? So that's really specific as a question. How to address the hesitancy in that age range, I suppose. These are folks who can have dose number 1 and are not stepping forward in Alberta, though, on how to get the message out, address hesitancy. In fact, that's the question, hesitancy towards vaccination, specifically on AstraZeneca. So if someone wants to talk about, yes, Darren?
It's a good vaccine. I mean, it was the only one that was tested during the uprising of the variants, and it's shown significant efficacy against the P1 variant in Brazil. Mm-hmm. This is kind of an embarrassment of riches, and people love car shopping. But what I think we really need to do is, be champions to our people who are hesitant. And there's very good psychology about how to deal with vaccine hesitancy. And the first thing you don't do is confront it head on. You don't try to be an expert opinion, but you do try to generate goodwill, and you do try to be a good leader. I think I've tried that myself. It's tempting to talk about these examples of relative risk, but when you're talking about this, it's, a good example is my partner just got the AZ vaccine. And even in the back of my head, I'm thinking about the risk of a vaccine-induced thrombocytopenia, which is minuscule, but it goes through your head. The relative risk, though, is as an intensive care physician, what we see through COVID is severe clotting disorders. So, your risk of getting injured driving to your vaccine appointment is significantly higher. But again, you don't want to be smug. You don't want to be a happy vaccine advocate, but you do want to be somebody who answers the questions when asked, volunteers your experiences, and, tries to open an accepting dialogue. They say physicians have made up their minds 12 seconds into a patient encounter. That's the absolute wrong approach. You got to listen and slowly direct people in the right direction. And there's not a simple answer to it.
That's a clear answer that you just gave. So great. Thanks for the example with the car accident being probably more likely than the risk of thrombose. So the last question from Valerie Wolf. Can anyone, so it's open for anybody, comment on the mitigation amongst the speakers indeed, on the mitigation strategy weakness in leaving so many workplaces open and operating and what role that plays in the transmission curve. There is a bit of context below, but the question is really that. So the mitigation strategy and the consequence on workplaces. So can someone talk about that specific thing? Maybe Yanni, are you raising your hand? Okay.
Sure, I'll take it. I think the first and most important thing is that when people are aiming for elimination, and they know that in a few weeks they will be able to open up normally, it's so much better because, first of all, people will agree to taking the most extreme precautions on a short period of time. And the most extreme precaution is just shutting down the opportunity for transmission. And instead, when things are going to go on for a long time, people look for excuses, reasons not to do things. And for example, people say, well, there isn't that much transmission here, or there isn't much transmission there. Most of the transmission happens in families, and then the transmission between families gets connected through workplaces, through schools, and through essential services. So the small amount of transmission in other places is what leads to a large amount of transmission across the community. And so what we need to do is to make it clear to people that there is a goal, that elimination is the goal, and we can stop it. And where there are essential services, really essential services, if people are motivated to prevent even the last possible transmission, then they will institute better precautions. And that has to be an understood to be goal, right? If you're living with a virus, then you're saying, well, a little bit more, a little bit less transmission, why does it matter? But when you're trying to achieve elimination, every bit matters. And so if you shorten the amount of time that you have to take the action, then you're that much closer to getting out of this and going back to normal.
Thanks. It's a great way to close our session today. Greatly thank you. Thanks all the speakers. Greatly, your presentation was absolutely great. Thanks to all the attendees to be with us up to this. It's been more than 1 hour and a half now. So thanks all. And the work is just beginning. It's a work in progress. We need to continue to push for zero COVID in Canada and abroad. So thank you, and let's stay in touch. Thanks very much.
Thank you.